with memory. So the reason why I say memory loss is, while this is a Alzheimer's disease and dementia care group, it's important to realize not all memory loss is dementia. So I always tell patients I focus on the care needs of the elderly patients, and I talk about because the best thing for us to do is try to determine what is the cause of the memory loss, and if it is something that's reversible. If it isn't, then we are dealing with the potentially we're dealing with the debilitating disease that we know of as dementia. I will definitely have time for questions, but I always like to take the time and opportunity when I engage with the community in settings like this to provide a general review of what dementia is, because often there is just some general misconceptions. I won't necessarily say confusion, but misconceptions about what it is, and that's often what I do in the clinic as well. When I make the diagnosis, I always ask the patient and the family what's their understanding of what that word means. Because often we have these thoughts of what it means I can't do, if I can make decisions for myself, or if I'm still able to do certain things for myself. But it's important to realize that it's a continuum, meaning that it does change over time. It doesn't mean that your experience or your family's, your loved one's decline will be similar to the woman next door or your friend at work's father. So everyone's experience and journey is different. One of the key components that makes each journey different is the support that the person has. And so that's why it's important for us to have opportunities like this to connect and share ideas, learn from each other, and hopefully grow as we work together to battle this condition. And when I say battle this condition, at this point where we are today in 2024, we do know that there is no cure. So we're constantly in a battle against the condition, but the best tools that we have is not necessarily the medications. The best tools that we have is trying to get a better understanding of what's going on with the patient and being able to provide the support for them as they change. And if we're able to provide the support for them as they change, then we will somewhat be able to predict how things will change. And it's conversations like this that help us understand, okay, this is where mom is today. I always say mom or dad. This is where mom or dad is today. This is where they could be next year, or this is where they could be in 6 months. Okay. So there's no way for us to predict how a person's decline will occur. I do think that the support has supported, and this isn't bashing anyone who doesn't have support, but if the patient isn't as supported, in my experience, I see that the patient experiences somewhat of a quicker decline. And that quicker decline is often linked to the fact that they still are responsible for certain things that they may not be able to do. And so they're working, trying to get it done because they knew they used to complete these things, and it causes them to decline at somewhat a faster rate from my experience. So I often, when I'm talking about what dementia is, so it is a neurological condition that impacts not only memory, but thinking and behaviors and a lot of different things. I often tell patients and families that what brings them to the clinic is memory loss. But what keeps them coming back, or what causes the greatest stress, is the changes in thinking, the changes in behavior, the changes in mood, the changes in sleep. So that's not necessarily memory. It's them getting agitated. It's them not realizing that they are. And so that you can say that's not what memory, that's really their thought processing. Who is this person in front of me? Why is this person that I don't know undressing me when it's really not about? And so all of those things are what keeps us up at night and causes the biggest amount of stress. So Alzheimer's and dementia. So we often hear those terms or words used interchangeably. Some of it is actually our fault, us being the medical community, because we just kind of throw them around. But dementia is the umbrella term. So if we think of, you can look at it two different ways. You can look at a house. If the house was named dementia, then everything in the house was dementia. But each room is something different. Because every house will have a living room, a bedroom, a bathroom. So there are different types of dementia, but they're all dementia. So Alzheimer's is the most common type of dementia. They aren't two separate things. And I say that every chance I get because often I'll have patients and families that'll say, okay, Dr. Carrol, I'm so happy you told me I have dementia. As long as you didn't tell me I had Alzheimer's. Okay. And the very next sentence that I plan to say is, I think you have Alzheimer's. So I always like to address that because that's somewhat the elephant in the room, because for whatever reason, we have been taught to fear Alzheimer's. Now, I'm not saying I don't fear getting old, I don't fear potentially losing some of my faculties, but people are really, really scared of Alzheimer's. And that's because it's always talked about. But from my perspective, I think the fact that we talk about it the most is that's the one that we're spending the most attention on, and that's the one that we hope to eventually have a cure for. So while it's very, sad to have Alzheimer's, I always try to provide some comfort to patients in saying that that's where a lot of the research and the intensity and the focus is on, so that we will continue to work to try to find somewhat of a cure. And so there are different types of dementia. So I always tell people when I'm thinking about what dementia is, I usually tell them to think of it as a house, or think of dementia as a family, and dementia is the last name. Because we might have the same last name, but I'm nothing like Sharon, I can present it differently, but we all are somewhat from the same family, but we're different types. So Alzheimer's, the reason why we talk about that one the most is because that's the most common. So 9 times out of 10, or really 7 times out of 10, if you meet someone with dementia, they're going to have Alzheimer's, generally speaking. But there are other forms as well. There's vascular dementia, which is rapidly increasing in the number of cases. But vascular dementia, vascular dementia is often the result of strokes. And so you can surmise why we think it's rapidly increasing, because the things that we could potentially help to target strokes, whether it be our blood pressure, our cholesterol, our diabetes, our eating habits, all of those things, and not exercising, that increases the risk of stroke. And when you have a stroke, it can impact parts of the brain that are involved with memory and thinking. And when it impacts parts of the brain that are involved with memory and thinking, it can lead to the development of vascular dementia. So think about that. Parkinson's dementia, fairly common as well. So these patients have Parkinson's, and we all know who's the most famous person that we know with Parkinson's. Muhammad Ali or Michael J. Fox. So it's funny that you both say that, because when I talk about it in clinic, those are 2 people that people bring up. Michael J. Fox. So I think he does that. Yeah, Rich Bryant. Yeah. So Parkinson's. So he has frontotemporal dementia. So Parkinson's dementia, those patients have Parkinson's disease. So that is a movement disorder. Generally speaking, Alzheimer's and other forms of dementia do not involve a movement disorder. So they generally don't have a tremor. They generally don't have tail rolling, where they're like always moving their hands, or they generally don't have shuffling gait. They're not picking up their feet all the way. So they have a movement disorder for a period of time, and then they eventually develop memory problems. Okay, so that's Parkinson's dementia. Lewy body dementia, somewhat similar. They have the movement component and the memory loss that occur within the same year. So people with Parkinson's dementia have Parkinson's for years, 2, 3, 4, 10 years, and then they eventually develop memory problems. So they have Parkinson's dementia. Lewy body dementia, they have the movement and memory within the same year. So it kind of hits them back to back. Frontotemporal dementia, which is what the young lady here brought up, is gaining a lot of attention now because a lot of famous people are coming up with it. So you may have heard of Bruce Willis. He was diagnosed with frontotemporal dementia within the last year. So it's a little different. Ironically, it's my favorite because I don't see it as often. But I always tell people, when you see someone with frontotemporal dementia, you know that's what it is. Because it either impacts behaviors at the beginning, or it impacts their language at the beginning. And Bruce Willis has the language on it. Now he can't speak. Like all of a sudden he could speak. I like the behavior part, but so I say Alzheimer's most common, vascular, that's what we have a problem with, and why we are getting more vascular dementia, because we are having more strokes, we are having more heart attacks. And y'all know what I mean when I say we. Okay, got it. All right. So we're having more problems with that, but it's impacting everyone. But I can say that we're seeing a disproportionate amount of vascular dementia cases in patients that were previously healthy. Parkinson's disease, Parkinson's dementia, Lewy body dementia, frontotemporal dementia, mixed dementia is somewhat of a garden variety, so they can have components of different types of dementia. So we just lump it together and call it mixed dementia. So that's generally the different types of dementia. And dementia can impact anyone, but most cases occur after the age of 65. So that's why I'm often involved with the cases. It can actually happen in younger populations as well. I actually don't know how old Bruce Willis is, but yeah, so frontotemporal dementia is one of the dementias that will impact people at younger ages. But you can have early onset Alzheimer's as well. Early onset Alzheimer's can be genetic, but that doesn't mean that if your mom had dementia, you will develop it. Okay. Most people that develop dementia in their 70s and 80s, they do not have the genetic type. Generally speaking, if it's the genetic type of Alzheimer's, it will express in your genes earlier in life. So most families that have genetic dementia, you'll be able to say, you know what? Well, Auntie had problems with her memory. She was real young. And then didn't our uncle have it too? And then Mama started to have it. So it impacts families because it's in the genes, so it's going to express. Another thing that we often look for is what they call penetrance, and that's essentially just penetrating, right? So when patients have the genetic form, it will penetrate so deeply in the family that almost in every generation, it's younger and younger and younger. So the first group may be in their 60s, but then their kids may be in their 50s, and then their kids may be in their 40s. So that's just an example. The youngest person I've ever seen with dementia, even though I'm a geriatrician, is 41. So that's the youngest that I've seen. I've heard of cases even younger, but the cases that I've heard of that were younger were the result of vascular dementia. But the genetic form I heard was 41. So, how do we manage dementia? So I sort of talked about different types of dementia. The reason why we say management and managing dementia, because we are not treating it. Generally speaking, when you treat something, it's a cure. So we talk about managing, so there are different managing techniques. Yes, there are medications, but just to reiterate, there is no cure. There is no cure. You may have heard of the newest medication that came out in July of last year, getting a lot of attention, lecanemab or Leqembi. That unfortunately still does not represent a cure, but it is available if you qualify for it, if you're eligible for it. There are some eligibility criteria that you have to meet. And we can talk about that during the question section if we want to. So there are medications that have been around for a while. You may have heard of Aricept or Donepezil. You may have heard of galantamine. You may have heard of Ranitidine, the Exelon patch. A lot of those medications are for mild dementia. And mild dementia is when the person needs assistance with what I call hands-off care. So hands-off care is they need somebody to help with their medications, their finances, the cooking, the cleaning, the driving, all that stuff. Hands-on care is what?
Activities of daily living.
So they need assistance with bathing or dressing. So you're physically putting your hands on the person. So if you're having to help mom or dad bathe themselves or dress themselves, not because of physical reasons, not because mom can't reach her back. We all might have problems with that. But because you put her in the shower and she's like, I don't know what to do. Like, why am I here? So that means cognitively, from a memory and thinking standpoint, she needs assistance with bathing. You lay her clothes out and she puts on her pants before her undergarments. She needs assistance with hands-on care. So once you start needing hands-on care, assistance in the bathroom, bathing, dressing, all that stuff, that's automatically moderate dementia. There's no debate about that. Mild, they just need somebody to pay the bills because they were forgetting. They need somebody to help them with their medication because they don't forget. They can't drive anymore because they were getting lost. That's mild. As soon as you have to help them get dressed, bathed, help them in the bathroom because they're flushing toilet paper or paper towels down the toilet, not knowing what's going on, that's moderate dementia. Okay. Severe is they start having more problems communicating. So significant language problems. Now you may say, well, Dr. Carrol, I thought you said that the language problems is only with frontotemporal dementia, like Bruce Willis. Remember, we're in the same family. So toward the end, we all look alike. But we start differently. So frontotemporal dementia, it often starts with problems with language. But when you think of severe Alzheimer's, at the end, they have problems with language. Okay? So they can't find the words. They can't explain what they need. So you have to, it's almost charades in the morning. What does mom need? Things like that. Okay. So that's just the quick and dirty of mild, moderate dementia. I often want families to understand that things will change over time, and that helps them understand how things change over time. So as soon as they know if I have to help dad with bathing and dressing and stuff like that, that's automatically moderate. Okay. I often say the mild stages of dementia are the most stressful psychologically for the caregiver. Why do you think it's more help psychologically?
Because they think they know what they're doing and they really don't.
Correct. So you're fighting with the person when they have mild because What you mean I can't take care of my medications no more? I'm gonna get in my car that I paid for, and I'm gonna go where I wanna go. This is how I talk in clinic. So that's what you're dealing with when they're dealing with mild. But when you deal with moderate and severe, it's more physically stressful. Why?
Watch them pick them up.
Because you might be picking them up, you're washing them, you're more hands-on. So hands-on care automatically is moderate and it's more physically stressing. Generally speaking, patients that have moderate dementia, they are not fighting as much with you helping. Now, they might fight you if they don't know who you are.
Well, yeah, it may not be running right this minute, but it is.
Going back and forth with you about I can pay my bills. Because when they moderate dementia, they don't even think about bills no more. That don't even cross their mind. That I don't care who paying, I'm just here, like, right. So that's generally, right? So I like people to understand the difference between mild, moderate, and dementia. Mild, moderate, severe. End stage dementia is after they can't speak anymore, but they also have problems sometimes sitting up. So they wouldn't be able to sit in their chair like Sharon, because if they don't have something to support their side, they'll go to one side or the other. Most patients with severe or end stage, they're bedbound. They can't get up and walk around anymore. Why can't they walk around? It's not that they're weak. It's what? Right. Exactly. So think of dementia as a problem with signaling. The brain sends signals to different parts of the body telling it what to do. Okay? Just like you just blinked, your brain told you to blink. Just like you said, your brain told you to do that. So, but we don't think about it. So we just, oh, I'm about to go, let me go. You just get up and you walk. But they may not understand, like, how do I get up? How do I initiate that? Because the signal isn't being sent. Okay.
That happened with Ava Rain. She got up one morning and, sorry, baby. That happened with Ava Rain. She got up one morning, went out to the door frame and put it on. We had to figure out how to get her back in bed. We put her in the hospital 3 days. They were trying to figure out why she could no longer walk, and then finally said, come here for nothing we can do. Sure, but the signal can't happen. You didn't have a clue.
So think about it like that. So probably what happened on the rain, she was able to get up, as you mentioned, but sometimes they'll get stuck. They'll get stuck, and literally the patient will be like I don't know if I put this foot next, or that's what their mind is unable to tell them. They're not verbalizing that. That's kind of what's going on. Okay. So most patients with severe dementia, they are mostly bedbound. And so that takes me to what I often have to talk about in the clinic is how grueling it can be to take care of somebody that has dementia. It is mentally stressful at the beginning. Oh, I'm sorry about that. It's mentally stressing at the beginning. It can be psychologically stressing in the middle to late stages, and it can really be draining at the end, where sometimes you have to make difficult decisions. These difficult decisions are truly difficult. And it causes us to sometimes sacrifice ourselves to take care of the patient. And while we love taking care of the patient, we have to realize that sometimes the patient's care needs can exceed that which we can provide in home. And if we cannot provide the care that they need, if we cannot turn them ever so often to prevent bed sores, if we cannot keep them safely in the home and prevent them from wandering off, then we have to either bring in support or consider placement. Okay? That is a conversation to have, but sometimes it's best. In fact, I personally think most times it's best. Because what I don't want to happen is that the caregiver to lose themselves taking care of the patient. Because if the caregiver loses themselves, then who's going to take care of the patient? Okay, so think about it like that. All right. Now, I'm trying to think of something else. Oh, so I talked about medications. So there are medications that can be used. The medications don't stop the progression. They don't reverse it. They try to slow it down. The newest medication that was approved last year, on paper, it does slow it down about 18 months, meaning it slows the progression about 18 months, but it's still progressing. Okay, so when you're having a conversation with your doctor about it, that's something to talk about. Are those 18 months important? So I've gone to a couple of conferences about it, and it changes from person to person. 18 months could be a lot for someone. It could allow someone to see their daughter walk down the aisle. So yeah, that is true. But it's important to know that it still isn't a cure. And this condition is still progressing. And there are some significant side effects that are concerning for me. But we talk about them and we make what they call an informed decision. We explain what could potentially happen. We're not saying that's going to happen, what could potentially happen, and then if we want to move forward, we move forward. Okay. The other thing besides medications for dementia, we can sometimes use medications for mood and behaviors. So we can talk about that as well, but I'll save that for the question section. Okay. So I hope I provided somewhat of an overview of what dementia is. I try to simplify it as much as possible because we're all family here. And I want to make sure that everyone goes home with something else, something new that they learn to help them understand. Because I think the key is normalizing the conversation. Because when we don't talk about it, it comes back to hurt us even more. So we have to have forums like this. All right.
Thank you, Dr. Carroll, for that overview. So we're gonna have a Q&A now. And I'm gonna have Dr. Carroll come sit where I am. I'm gonna walk around with the mic because again, we need to use the mic in the room. And then Dr. Carroll can juggle back and forth between online and in the room. Online, if you have a question, please put it in the chat and raise your hand. And then that way, Dr. Carroll here, it'll tell you who has their hand up and in what order. I'm sorry, you don't have to put it in the chat. Just raise your hand and he'll call on you. You can take yourself off mute and ask your question.
It looks like it's one question. Is that one question already in the chat? I just don't want to. And I can be checking if there's one.
I'm looking for can you hear me?
I can hear you, yes.
I would like the names of the newest drugs, please, so I can write them down. I heard the names, but I didn't take note. I'd like to, please.
Lecanemab.
Spell, please.
LECANEB.
B like boy.
Yes, ma'am, at the end.
Okay, and there was another one, I think.
So Leqembi, that's just the brand name.
Okay.
So that's the most recent one that was approved last year.
Okay, thank you. I'll discuss it.
All right. So the medication is very expensive. Kimby, it is, there's still some debate about if it's gonna be covered by Medicare, but my understanding it is gonna be covered by Medicare. But it's, I can't remember the exact price, but I know it's like 20,000 or something. A lot of medications we take are very expensive that are covered by Medicare, but it is very expensive
20,000 per
per dose. For what? Dose.
And is it an IV?
It is an IV medication.
So how long does how long is the effect of the pill?
So it's about 18, it delays the progression about 18 months.
So you take it, what, you mean the process of taking the meds, like for how often would he take it, every day?
So that's a great question. So it is an IV medication. So it's not a pill. It's infused in a center, like at the hospital or in some type of infusion center, almost like you're getting a blood transfusion. It's infused one dose every 2 weeks for, I can't remember, I wanna say it's 6 or 7 months. One dose every 2
Wow.
weeks.
Wow.
And they take it for how long? For the 18 months, is what we're saying? Is that the period of time that one would take it? 18 months?
No, it delays the progression about 18 months.
And so you would take it for how long?
So I can't remember exactly, but I think it's like 6 or 7 months. So
Okay,
we've had it, within our system since October. And from my understanding, there's only been one person that's entered the protocol.
Wow.
So that should show that it's not being used as much because of, and I'll address that. So that the main, it's not because of cost, because believe it or not, you know, if it's covered by insurance, the Medicare is covering it, people will wanna take it, like if you have a copay or whatever. But the main reason people don't wanna take it is because of the potential side effects. The main side effects and the reason that I have significant concerns is the risk of brain swelling
Mm,
and brain bleeding.
mm.
So
okay,
the data supports, although the data tells us that it does delay the progression about 18 months. So it does slow it down, and this is the first thing that truly slows down to that degree. So I gotta give the makers that.
side effects, oh.
Yeah.
But the two side effects are concerning for me because about 1 out of every 5 people that took it had one of those side effects.
Ooh,
Mm,
that's, yeah.
that's tough.
And some that's a concern to me. Sorry. That's a concern to me. So people are taking it. You know, outside of the system, I have colleagues that are involved in administration. Some of them have had patients with some of the side effects, some of them have not. I am not saying that you shouldn't discuss it with your provider. I'm not saying that it's something you shouldn't pursue, because that's a decision for you to make after appropriate discussion with your provider, okay? The other thing is you have to meet the inclusion criteria, the qualifying criteria. Leqembi and lecanemab, same medication, sorry, is approved for mild impairment or mild dementia. It is not approved for moderate or severe. Okay, so what does that tell us? For a lot of the patients that I'm taking care of, they wouldn't even qualify. But I'm still telling them about it because I don't want them to think I'm withholding the information. But they don't qualify for the medication because they already either have moderate or severe dementia. All right, did that answer your question, Cleo?
Yes, it did. It did.
Okay.
Thank you.
Okay, we want to go back and forth, right?
When you were mentioning the medications, you said for mild, there was a patch.
So there are a few medications that are for mild, but the most commonly used is Aricept or Donepezil. That's a pill. But one of the main side effects of that group of medication is upset stomach, nausea, vomiting. So the makers of that group of medication came up with a patch. It's called an Exelon patch. It's ribostigmine, so it's similar to donepezil, but it's just a patch. Patients that use the patch, because it bypasses the stomach, they have less GI effects, so they have less nausea and diarrhea and vomiting. It still can happen though, because it's the way the medication works. But there is a patch
And it's for mine.
for mild.
Okay, thank you.
All right, so Lori Hunter Hawkins.
Good morning, Dr. Carroll, to everybody that is a caregiver.
Yeah.
This is a blessing because you were actually the doctor that diagnosed my mom. And so I think my only question right now is, are you located in the same place?
So it's depending on when I saw your mom. So I have moved, I'm still within West Los Angeles. But
Okay.
I don't know when I saw your mom, so I used to be at, on the corner of Inglewood and Washington Boulevard. But then during COVID, I moved to the main hospital, which is Cadillac.
Oh, Cadillac. Okay. That is great to know because you were in your previous place. And so I guess we just kind of lost track. She has a good physician, but it's getting to the point. I think she now is in the moderate stage. And I just want to keep up with any, things that would be beneficial to her.
Okay, definitely. Feel free to reach out to you're still within the Kaiser.
Yes, she is a spouse, a Kaiser spouse member, so she has K coverage. So this would be covered for her.
Okay, all right. Well, feel free to reach out and we'll love to see her again.
Okay, thank you.
No problem.
Hi there, Dr. Carroll. You also have also diagnosed my mom, auntie mom. And I know it's score, it's like a score that, or some type of criteria score that tells you where they are, like, right? And I don't remember her number, and we haven't been back. I've been twice, but we haven't been back since. If we come back to you, can you determine if they're mild or moderate?
Yeah, I can actually probably determine mild or moderate with you and I having a conversation.
Okay.
But the number system that you refer to, the number system is in place still, but what I've talked about already is essentially the numbers. So mild is 4. Okay, so you may ask, well, why do we jump all the way to 4? What was 1, 2, and 3? The staging system that we use includes staging for everybody, even if you're cognitively intact, which is what I think I am. So 1 is no problem at all. 2 is you sort of start to think you're forgetting some things, but you're still functional. 3 is it's clear that you're forgetting things, but you're not having any impairment. It's frustrating, but it's not impaired. And then 4 is when you have the diagnosis of dementia. Okay. And then, so that's mild. Moderate is 5. And what does moderate mean?
Hands on.
Hands on. That's Mr. Gregg, right? All right.
Yeah.
So hands on care, right? So 5 is hands on. That means that they need someone to pick the clothes out for them because they wouldn't be able to do it. They may want to wear a bathing suit to church. Just using as an example. So their thought process is just it's not clicking anymore. And then when you get into stage 6, they have sub stages. So 6A, 6B, 6C, 6D, 6E, then 7, 8, 12.
That's the follow-up or circle back?
And also in the follow-up question, because I don't know exactly what stage she's in, but I do know there's definitely a difference, cognitively. Praise God, she's able to choose her clothes and all that stuff. However, I don't know how she's thinking, but I think for her, sometimes she'll say things like, I feel like I'm in 2 worlds. And then she'll start to, she's constantly aware and knows certain things, but somebody might be like, and then for me being the caregiver and then also her daughter, it becomes constantly combative. And I'm not saying combative, I'm not like we're like, but it's becomes a frustration for me, because I'm like, no, that's not right, or something, and it becomes an argument.
Mhm.
So my question to you is, as a caregiver, this is where we at right now. Do I just not talk to her? I mean, like, I talk to her, but like, how do I?
So the easiest way for me to answer that question is, if whatever you guys are talking about, if her answer does not impact her safety, just let her have it. So if she tell you it's 1959, it's 1959, we can go with it. But if she tell you, you know what, I gotta go to work today, I'm about to leave the house, then you gotta be like, you're not going nowhere.
Okay.
Does that make sense?
Yes.
Because it helps you manage your stress. Now I've had family members say, Dr. Carrol, I can't do that because I don't want to run myself crazy. Like thinking it's 1959. Right. So because but I always tell them, as much as possible, if you have an understanding of what the condition is, because you're still cognitively intact, you can sort of go in and out of their world, because they are in that other world in a way.
It's like when she sees the doctor, and the doctor's trying to help her and say, okay, she goes to physical therapy. Well, he didn't say for me to work on it every day, so now it's like, we're going back, I'm like, because I'm trying to help the situation, but it's like, she wants to come back there, so it's not about the things. But just to help, like medication or, physical therapy, things to try to help and promote her health and further being here. That's the part, and I don't know where we are in that, so we're going to see. Thank you.
All right, no problem. Next question is Jasmine, online.
Good morning. I came in very late. I couldn't log in, but anyway, I'm here. And I believe, well, my question is I'm still confused with the clarification. When I read different material, to me, it sounds as if there's 3 different diseases. Is it, okay, so it's MCI, mild cognitive impairment. Then there's 8 different dementias, and then there's Alzheimer's. Is dementia and Alzheimer interchanged?
I did record it, so if you wanna get the short version, and I'll send out the recording.
So Alzheimer's is a type of dementia. So Alzheimer's is a type of dementia. So everyone that has Alzheimer's has dementia, but not everyone with dementia has Alzheimer's. So think of it as everybody in this room, everybody in this building is in this building, but we have different names. So we have different experiences, different living situations. So we're all in this group together, but it's different types of people. Does that make sense?
Yes.
If it doesn't, I can explain.
Well, no. Well, I believe, okay, so just because you have dementia doesn't mean you're gonna have
We have
Alzheimer's.
Alzheimer's.
Okay, and Alzheimer's is a specific type of dementia.
Yes,
Okay,
it is a type. It's like a color. They're all colors, but this is red, this is blue.
I have a
Alrighty.
question.
Okay, well, wait one second. Do we have anybody in the audience? So we have one more in the center, and then was that you, Karen?
Yes,
Okay, and then I'll get you next, okay?
okay.
I'm gonna be next to my question. I have a friend who lives in Texas. So in our last few minutes, I'm gonna stop the recording, and I will be sending out the recording probably before I leave here today. It's gonna not be where it's at. I got it.